So the talk is about POCUS in acute kidney injury, looking beyond the renal collecting system. So it's to essentially challenge the notion that point of care ultrasound in AKI is mainly just to exclude the hydronephrosis. There is much beyond that. And I do not have any disclosures or conflicts of interest. So first, what's acute kidney injury? Obviously, we know that it's acute dysfunction of the kidney, but actually there exists a definition. You would probably see these grades only in the nephrology note and nowhere else. But so in general, AKI is increase in serum creatinine, the absolute value, by more than or equal to 0.3 milligram per deciliter in the preceding 2 days. Or the most commonly used or accepted definition actually is increase in serum creatinine to more than or equal to 1.5 times the baseline. That is presumed to occur within the past 7 days. And you can also go by the urine volume, especially when you don't know the baseline serum creatinine. Urine volume less than 0.5 ml per kg per hour for 6 hours is still considered AKI. And this staging you commonly see in the note, it's just a way of saying how severe AKI is. It has prognostic implications, but largely consensus based rather than randomized control trial based data. But regardless, so stage 1 is 1.5 to 1.9. So 1.5 to 1.9 times the baseline. So you can easily remember by stage 1 is in ones, so 1.5 to 1.9. Stage 2 is 2 to 2.9 times the baseline. That is, stage 2 is in twos. And stage 3 is more than 3 times the baseline. Or if the patient requires renal replacement therapy for whatever reason, you call it stage 3 by default. There are urine output based definitions also. I just removed them. And what are the common causes of AKI? This is like very basic slide, right, for like medical students pretty much. But so in general, AKI could be either hemodynamic, previously used to be called pre-renal, but we use the term hemodynamic now just to stress the fact that even congestive kidney injury is also included in this, and pre-renal is commonly used to denote volume depletion. And you can have intrinsic renal injury or obstructive renal injury. And obstructive is the most common thing that you would want to exclude using kidney ultrasound. And hemodynamic can be because of impaired forward flow in cardiac failure, or because of venous congestion, or it could be because there is blockage to the flow, blood flow to the kidney, which could be because of either vasoconstriction that typically occurs in hepatorenal syndrome, or thrombosis, such as in thrombotic microangiopathy or venous thromboembolism. And glomerulonephritis, you can leave it alone. And tubular injury is mainly of 2 types: acute tubular necrosis. It's better called acute tubular injury because it's not really a necrosis, which it is commonly seen because of prolonged hypotension, and acute interstitial nephritis, which is commonly because of drugs. And obstruction can be because of many things you know better than me. So how can we utilize point of care ultrasonography to in each of these etiologic variants of acute kidney injury? It may not always provide the final diagnosis, but it will at least help to narrow the differential and plan further management. So the first things first, so obstructive nephropathy. So first of all, how common is obstructive nephropathy? It's only about 1 to 3% of cases of AKI that you see in the ICU. And about 15% of non-ICU AKI cases, and about 10% of community-acquired AKI. So if your practice is mainly based in ICU, the incidence is pretty low. I mean, or the chance that you would find management changing obstructive nephropathy is pretty low. But why do we do it? It's because it's very easy. It's a component of physical examination, and it's potentially treatable. And in the incidence in ICU is probably low because the patients, most of them already have a Foley catheter in place by the time the patient goes to ICU. Or for that matter, even in nephrology practice, it's really very rare for me to see a management changing obstructive nephropathy, because by the time we are consulted, the patient either has a formal ultrasound that is performed by radiology department or has a Foley catheter. And we all know how hydronephrosis looks like. On the left side is the normal kidney. You can see the liver on the top and the bean-shaped kidney. And you have the cortex here. You see these anechoic medullary pyramids, and a major chunk of the kidney is formed by the sinus fat that surrounds the collecting system. So collecting system is not visible in a normal kidney. On the other hand, when you have hydronephrosis, the collecting system enlarges, and because urine is anechoic or black, you see this dilated collecting system as a black branching structure here. I'm not going to bore you by talking more about hydronephrosis, but I'll show you a few cases which are interesting in the setting of obstructive nephropathy. So first case, here's a 72-year-old woman with history of Crohn's disease on vedolizumab therapy. Vedolizumab is a monoclonal antibody, anti-inflammatory antibody used in this disease. It's against integrin. But anyway, she also has hypertension and CKD stage 3 with baseline creatinine of about 1.4. And she presented with AKI with a serum creatinine of 5.8. Ultrasound was done, and it shows that there is some maybe mild to moderate hydronephrosis of the right kidney. And also you probably see a small simple cyst. Other than that, really nothing remarkable. And left kidney also shows some, you can say mild hydronephrosis or some dilatation of the calyceal system. And nothing was really found in the bladder. But the patient was not really improving. With the patient got a Foley catheter, and the creatinine was not improving that much as expected. Renal ultrasound was repeated. And here, again, you see this moderate hydronephrosis in the right kidney. You see something here, like it looks pretty much like you would see a descending aorta in a plaques view of the heart. So some funny thing here. But on the left side, you can see this odd thing better. So you do have some hydronephrosis, but you see something around the kidney that is of heterogeneous echogenicity that seems to be engulfing the left kidney. So it turned out that the patient had a B-cell lymphoma that's involving bilateral kidneys. On the right side, it was not very visible on ultrasound because it was mainly involving the distal part of the collecting system, periuretral region. On the left side, it was visible on ultrasound as an engulfing mass. So going back to the ultrasound, so all this mass is a retroperitoneal lymphoma. So the point from this case is, I mean, don't hesitate to repeat ultrasound when you're in doubt. I mean, it's just a physical examination as you would auscultate every day. Just you can, whenever, I mean, obviously whenever there is an indication or when things don't go as you expect, repeat ultrasound and also look around the kidney. It's not just looking at the collecting system, but also around the kidney, you might get some diagnostic clues. And interestingly, in this case, I mean, there was a CT scan available from 1 year ago, and it was clean. And this monoclonal antibody could have a role in causation of B-cell lymphoma. And another case, here's a 64-year-old male with no known medical history, otherwise healthy, presents with a creatinine of 10.5. He was still making, he was never really oliguric. And the initial kidney ultrasound shows, I mean, fine. I mean, it's really nothing that remarkable. Maybe length is a little lower. I don't have the scale here. This is one of my case reports. I couldn't find the original files, but so the parenchymal thickness seems to be relatively preserved. And there is no frank hydronephrosis. The arrows point to maybe a little bit, prominent collecting system. Other than that, really nothing remarkable. And the patient's creatinine also was not improving, and actually he complained of some abdominal pain for which a CT scan was obtained. And what it showed is periaortic fibrosis and periuretral fibrosis. You can see the periuretral fibrosis better in this coronal view. So this patient had retroperitoneal fibrosis, which was compressing the ureters. Nephrogram was done, and bilateral ureters showed this kind of thinning and narrowing. And the patient got bilateral stent placement, as you can see in this CT image. And surprisingly, the serum creatinine has improved to 1.3 just in 4 days after stenting. Remember, he presented with creatinine of around 10. And there was no hydronephrosis, but still, this is obstructive nephropathy. You can have obstructive nephropathy without hydronephrosis on ultrasound. That's a very important thing to remember. So, and retroperitoneal fibrosis may do this. And also, you can see the similar phenomena in patients who are like severely volume depleted at presentation and who may develop hydronephrosis on repeat scans. I saw such patient who had risk factors for obstruction, had some neurogenic bladder, and presented with AKI and hypercalcemia, probably had hypercalcemia induces diuresis, right? So the patient was severely volume depleted. And we thought he has risk factors for obstruction, but he doesn't have obstruction. But repeat ultrasound showed hydronephrosis after volume depletion. So again, the take-home point, hydronephrosis can present late, or it may not even present, but the patient can still have obstructive nephropathy. Here is another interesting case. A 57-year-old woman presented with fever, abdominal pain, and nausea. And she was found to be hypotensive, had leukocytosis. So, picture suspicious for sepsis. And CT scan was done in the ER, but it was a CT scan without contrast. It showed mild hydronephrosis bilaterally, but otherwise unremarkable. So the patient was deteriorating. So they performed exploratory laparotomy to find a septic source. But it couldn't really find any obvious source. And nephrology was consulted for CRRT as usual. Obviously, the patient has AKI, so you always want CRRT. So nephrology gets kidney ultrasound, and this one here shows, it was similar picture in both kidneys. I just put the right kidney here because it was better visible. So you can see in the transverse axis, you can see this dilated ureter. Here you can see hydronephrosis inside the kidney. It's still mild, but what you see differently is this echogenic material within the collecting system. That's pus in the collecting system. So when you have, it can occur as a complication of pyelonephritis. You can form pus, and that pus can obstruct the collecting system and lead to hydronephrosis. So this is a case of pyelonephrosis, and the patient got like bilateral nephrostomy tube placement and antibiotic therapy, and the patient went home without any need for dialysis, and the creatinine remarkably improved. So always get an ultrasound. What happened in this case? Like, why did she get unnecessary laparotomy? Was CT scan without contrast might not be able to detect this. CT scan with contrast would show some layering, debris, and contrast, so you would be able to detect it. But without contrast, can miss. So that's one problem with this. And here is a nice example shared by you guys, actually, like 2 days ago. Here's a kidney that shows pyelonephrosis. So if you observe closely, here this white material, it's like a chain of stones. That's a Staghorn Calculus, actually. So Staghorn Calculus goes into the renal collecting system. So on ultrasound, because the shadow starts from periphery, you would see like a chain of hyperechoic things. And the green arrow points to this echogenic material within the dilated collecting system that points to pus or pyelonephrosis. Actually, emphysematous pyelonephritis can look pretty similar. If you don't know that this patient had a Staghorn Calculus from before, this could also be like air in the collecting system, because air in the collecting system also appears bright. So I wouldn't really be confident in just saying this is pyelonephrosis. It could also be emphysematous. If that's the case, I would get a CT scan. Because CT scan would be able to tell you the exact extent of air and guides therapy. But regardless, this is a great example for a Staghorn Calculus and pyelonephrosis. And another common trap is mistaking a parapelvic cyst for hydronephrosis. Cyst is well circumscribed, and unlike hydronephrosis, which is usually a branching structure. So if you have a distal obstruction, the pressure should go back into the kidney, and the collecting system should dilate and branch into the kidney. If nothing is branching into, but there is just like a small or big ball within the kidney, you should suspect a cyst. Or sometimes you can have extrarenal pelvis, that is the pelvis located outside of the kidney parenchyma, that can get distended even without any backflow or back pressure in a regular state. That can be confused with hydronephrosis also. So this is a common trap. And never forget to scan the bladder. And ultrasound renal ultrasound is never really complete unless you scan bladder, especially when dealing with obstructive nephropathy, or for that matter, any case of AKI. For example, in this case, you are seeing full bladder despite having a Foley catheter. That's another common mistake, that because the Foley patient has a Foley catheter, we tend to assume that the obstruction is ruled out. But here you have the Foley balloon nicely sitting within the bladder, but the bladder is still filled with anechoic urine. So this is a case of obstructed Foley catheter. So you have the Foley balloon, but still the bladder is full. And here on the left side, you can see how a bladder is supposed to look like when it is adequately decompressed by Foley catheter. That's the deal with obstructive. So I did not really go into depth. Obviously, you know more than me like in terms of like various scenarios, stones, obstructing stones, those twinkle artifacts and stuff. But I hope those cases were helpful. And now coming into intrinsic causes of kidney injury. The first thing, ultrasound is pretty non-specific. It cannot diagnose any particular intrinsic cause of kidney injury, but what it can tell you, especially when you don't have a baseline serum creatinine available, is whether this is more likely to be acute kidney injury or more likely to be having some underlying significant chronic kidney disease. For that, you need to look at renal length and parenchymal thickness. So normal renal length is about 10 to 12 centimeters. So it varies slightly depending upon your height mainly, and also weight. But more or less, it's about 10 to 12 centimeters. It's commonly said that a person who is less than 60 years old will not have a kidney that is less than 9 centimeters. Cortical thickness is from outside of the kidney, like this yellow thing here, to the outer border of the medullary pyramid. But in real life, you don't always see medullary pyramids this clearly. So if you're able to measure the parenchymal thickness, that's fine. So normal cortical thickness is 0.7 to 1.1 centimeters. So I would say approximately, just remember, 1 centimeter. And parenchymal thickness is outer border of the kidney to tip of the medullary pyramid, or till you see the sinus fat. And that's almost twice as much as cortical thickness, and it's about 1.4 to 2 centimeters. And in chronic kidney disease, typically the length of the kidney and parenchymal thickness decrease. And while your patient with unknown baseline kidney function has big kidneys with preserved parenchymal thickness, that's more likely to be acute kidney injury. Of course, there are exceptions, like you could have diabetic nephropathy with relatively big kidneys, and you can have some deposition diseases with relatively big kidneys with underlying CKD. But in general, CKD kidneys tend to be thin. The next factor is cortical echogenicity. That's another thing you would look at. And when we say cortical echogenicity, we are comparing the relative echogenicity, or how bright the kidney cortex is compared to that of liver on the right and spleen on the left. And renal cortical echogenicity increases in many things. It's pretty non-specific. The radiology often reports there is increased cortical echogenicity and there is medical renal disease. It just means that there is no obstructive nephropathy. It doesn't mean medical renal disease is chronic kidney disease. It's any kind of parenchymal kidney disease. So increased echogenicity has good specificity for parenchymal kidney disease, but not synonymous with CKD. That's the take-home point. And it can increase in CKD because of glomerulosclerosis and interstitial fibrosis. And you can have increased echogenicity in glomerulonephritis because of inflammatory infiltrates. Same thing with acute interstitial nephritis. You can have increased echogenicity, or even in acute tubular necrosis because of proteinaceous tubular casts. And you can have decreased cortical echogenicity in cortical necrosis, which is typically seen as a pregnancy complication. Or you can see local hypoechoic cortex, particularly in case of infection, such as pyelonephritis. Here is an example of a patient on dialysis, ESRD kidney. The length is only 7 centimeters. And you can see there is pretty much no visible cortex. And it's pretty bright all over. And here is a transverse section or transverse axis of the kidney that shows the increased echogenicity better and a very thin parenchyma. So this is definitely ESRD kidney. And here is an example obtained from a patient with lupus nephritis and presenting with acute kidney injury. Here you can see like very significantly elevated echogenicity compared to that of adjacent liver. And here is the left kidney. You can see that like the kidneys are thick and the parenchymal thickness is very much preserved. And the length of the kidney is also very much preserved. It's about 12 centimeters. So in any kind of active glomerulonephritis, you can have increased cortical echogenicity. Here is another case of a biopsy-proven ATN. This was a young patient who presented with influenza and had prolonged ICU stay requiring ECMO and all that. So required CRRT in the interim. And the kidneys looked like this. So a big preserved parenchymal thickness, increased echogenicity, the length is preserved. And most of these cases, you would see actually medullary pyramids appear more prominent. That's just because the surrounding cortex is more echogenic or bright. So anytime you see prominent medullary pyramids, apart from kids, in adult patients, I mean, so look carefully about cortical thickness.
Protect your speaker.
And very interestingly,
Right.
I put the same picture
So
on
you didn't see it before.
Twitter poll recently, and
There are two tabs.
only about
Leave
25%
computer
of the
audio
patients
and then
got
get
it right. They
other
chose
audio.
acute kidney injury, and a significant proportion chose chronic kidney disease. That means those people have mistaken increased echogenicity for CKD, and the people who said obstructive nephropathy, I'm assuming probably they confused the these vessels here and the vertebral shadowing for probably for stone and obstruction. Obstructive uropathy. And I have no idea why a third of participants chose medullary nephrocalcinosis, because medullary nephrocalcinosis is exactly the opposite. Here is an example where you would see actually white or bright pyramids and not more blackish pyramids as you would see in a case of increased echogenicity. Just to show an example. And this is a nice example of medullary nephrocalcinosis. And another interesting case of intrinsic renal cause. Here is an elderly gentleman. I saw this patient in the clinic very recently. He's otherwise healthy, like about 70-year-old Caucasian male. Hypertension is also very well controlled. No hypotensive episodes or anything, but presented with AKI. The creatinine rose to 3 point something when I initially saw him, and the baseline was about 1.1-ish. And the kidney showed markedly increased echogenicity on clinic ultrasound. So in my clinic note, I wrote, I suspect the two primary differentials would be either it's a deposition disease, that's common thing that elderly patients present to nephrology clinic with unexplained AKI and found to have multiple myeloma, or I think it's AIN. So these are the two of my major differentials, though I cannot say based on this non-specific features. So it turns out that the biopsy showed this. So what you see here is, first, you see a lot of blue things here. So blue things are cells. So that means there is a lot of cellular infiltrate in the interstitium. That's one thing. So my prediction about having interstitial nephritis is correct. And on top of that, you see something more interesting. that these arrows point to here. So you notice these glassy structures, better seen on this polarized microscopy here. So they light up here. So these are calcium oxalate crystals. And remember, I mentioned he was taking vitamin C and D for COVID-19 prophylaxis, poor guy, because somebody said they can boost the immune system. So what happened is oxalate nephropathy is seen as a complication of too much vitamin C. And ascorbic acid gets converted into oxalate, and that can get deposited in the kidney and cause oxalate nephropathy. This is a very unfortunate situation. And simultaneously, if you're taking vitamin D and you don't have vitamin D deficiency, it causes hypercalciuria, and that calcium and oxalate passing through the kidney probably led to all this calcium oxalate formation. This is very unfortunate scenario because this anecdotally has poor prognosis, and this patient I started him on steroids for the inflammation component, but didn't really respond and ended up in hospital. We initiated him on dialysis. I hope he recovers, but that's a bad thing. So you need to be aware of this thing, especially in ER setting or even in the ICU setting. There are case reports where in some ICUs, patients received IV vitamin C and patients developed oxalate nephropathy. Okay. So based on my experience, I would just say in general, in clinic, if you're seeing a patient with relatively preserved parenchymal thickness and hyperechoic kidneys, the first differential would be AIN, acute interstitial nephritis, most likely from some over-the-counter medications, or paraproteinemia, then some kind of glomerulonephritis, or you would also want to rule out HIV, because HIV-induced nephropathy can have big hyperechoic kidneys. We don't see that often these days because patients present early and we have better treatments, but that used to be like a very common differential previously. And if you're seeing inpatient with similar picture with big hyperechoic kidneys, most of the time it's ATN, and the second differential would be AAN, because in inpatient setting, most likely the patient experiences hypotension and is subjected to drug therapy. So these are the two common causes. It's very rare that some kind of acute GN is presenting in the inpatient setting, except for maybe post-infectious GN. Okay, so that's the point. And how about this? This is the last case of intrinsic kidney disease. So this is a patient with right flank pain, otherwise young female, no known comorbidities, like just had like severe flank pain, came to the ER. And is there anything suspicious for intrinsic cause? I mean, there was really, the urinalysis was remarkable, like really unremarkable, meaning there was no blood in the urine, no white cells in the urine. Did have some subjective fever, but there was no measured fever or elevated temperature. So it looks pretty normal. I mean, there is no obstruction. There are no obvious stones. I mean, maybe there is some like hypoechoic area in this region. Maybe it gives a little bit of heterogeneous appearance to the parenchyma, but nothing really, right? So what's the next step you would do? Kidney ultrasound, again, is never complete without bladder ultrasound, and also never complete without you doing at least one color Doppler image. So the color Doppler image shows this spectacular pattern where there was blood flow only to one part of the kidney, and the top portion of the kidney is completely bloodless. So, and the CT scan eventually showed a massive renal infarction. I mean, it's strange that like we couldn't find any cause of renal infarction despite doing angiogram and all the hypercoagulable workup and all that stuff. And it is said that about 30% of the patients can have idiopathic renal infarction. So this is one important thing, I think, especially for in the ED setting, never finish without a color Doppler image. Okay, very good. Now your favorite part. And like you finished with obstructive component and intrinsic kidney disease, and then the hemodynamic causes. So hemodynamic causes, forward flow and venous congestion component. Forward flow is, I mean, you can look at other parameters. How is the cardiac output? How is the overall clinical picture? How is the skin and all that? And for venous congestion, obviously, Dr. Eduardo has given an amazing lecture, I assume, because I couldn't attend, unfortunately, because of the clinic, but I know him, obviously, so I know what he must have spoken. So you're all like very much well-versed with VEXAS now. So In general, organ perfusion pressure is dependent on both inflow pressure and outflow pressure. It's a difference between these inflow and outflow, or in other words, when it comes to kidney, it's MAP minus CVP, or intra-abdominal pressure when elevated. So afterload or increased outflow pressure is very much important, but we tend to commonly give more importance to the inflow pressure or decreased perfusion of the kidney. So thanks to all the vexillologists, now we have a way to measure the venous congestion or way to assess the venous congestion more objectively. And we also know that increased CVP from any cause, it could be heart failure, heart surgery, mechanical ventilation, pericardial effusion, pulmonary hypertension, increased intra-abdominal pressure, or indiscriminate fluid use in septic patients. Anything, when CVP increases, there is increased kidney afterload or increased outflow pressure leading to congestive kidney injury. So congestive nephropathy is relatively a new term, or it's an underutilized term or diagnosis. And VEXUS gives us the opportunity to evaluate this further. And I'm not going to talk about hepatic or portal waveforms, just to take a closer look at the intrarenal Doppler. To get a good intrarenal Doppler, first, obviously, you have to get a good 2D image of the kidney, and then turn on the color Doppler. And not every patient has this nice color Doppler images. Sometimes putting power Doppler helps because it's a little more sensitive than color Doppler to identify a vessel. And you want to do the intrarenal Doppler intrarenally, that is within the kidney, because kidney is a closed system, and all this elevated venous pressure and interstitial edema from that leads to a renal tamponade. So you want to see how the kidney parenchyma is feeling the pressure. So you would want to choose an intrarenal vessel, typically an interlobar vessel. So interlobar vessels are those just beside the renal pyramids, and then they loop around the pyramid as arcuate vessels. So you can do in either arcuate vessels or interlobar vessels, but if you look at the direction of the ultrasound beam, interlobar vessels are more parallel to the ultrasound beam, so you get a better image. And if not possible, you may be still be able to do it in segmental vessels, a little downward here, but typically not anything outside the kidney. And you get this image and then turn on the pulse wave Doppler, you put your gate at the interlobar vessel, and you get a tracing like this. Most of the time you get arterial and venous tracings together, which is a great thing in kidney, because the simultaneous arterial tracing works as a built-in EKG. It tells you the phases of cardiac cycle. So the arterial waveform is depicted on top of the baseline, above the baseline, because it's red on color Doppler to flow towards the transducer, and the venous waveform is below the baseline. And normally venous waveform is pretty continuous. And here arterial waveform, you can see systolic peak, and here the valley diastole. So systole, diastole, systole, diastole. Now, if you have any flow alterations in the vein, you would know if it's occurring in the systole or diastole just by looking above the baseline. And with elevated right atrial pressure, with increasing right atrial pressure, this is how the waveform changes. So it's just like a revision for you. But so normally it's more or less continuous. You can have these small dips at the end of each cardiac cycle. They correspond to a wave of hepatic. Actually, if there is no arterial tracing on top, you will be able to see a waves like in the second picture you are seeing. But anyways, with increasing right atrial pressure, you seem to, the pulsatility will increase, and the waveform becomes more discontinuous. With further increases, you will see two distinct S and D waves. That is, this part of the venous waveform is occurring in systole, and this part is occurring in the diastole. This is S wave, this is D wave. They say like initially S wave is bigger than D wave, like you see in hepatic vein, and then with the further increases, D wave becomes bigger than S. It's not always easy to appreciate those changes, but in general, biphasic or distinct S and D waves is bad. And as the RAP increases further, there will be systolic flow reversal, and you'll have only D wave below the baseline. So you know that this is D wave even without EKG, because you are seeing the diastolic flow above the baseline. That is the arterial diastolic flow. And there will be a systolic flow reversal. You can see the systolic wave here if you do not have simultaneous arterial tracing. I'll show some examples. And yeah, here is the anatomy of biphasic intrarenal venous waveform. This is how it actually appears if you do not have a simultaneous arterial waveform. Here is this first one. This yellow thing is you have the arterial on top. Yeah, you have the venous with distinct biphasic S and D waves. And if you do not have arterial tracing, you can actually see both A wave and V wave. Actually, you can see like faint arterial tracing here. So you clearly know that just before the systole, you have this A wave, you have S wave, you have this retrograde V wave, and then D wave. A very nice pattern, which is exactly the same as hepatic vein pattern. Okay. And that's venous waveform analysis. And coming to arterial waveform analysis, this waveform also gives you some information in certain circumstances. So normal arterial waveform is like this. You have this systolic peak and a diastolic valley. And if you see this kind of waveform, which is like a slow rising thing and decreased velocities, it's called Parvas-Stardust waveform. It's like a weak and slow rising pulse, like you would see in aortic stenosis, like a Parvas-Stardust pulse. So it's the same as that. You can see this when there is a proximal obstruction, or not necessarily structural obstruction, but there is some high pressure before the point you are measuring the blood flow. So for example, in renal artery stenosis, you can see this pattern. Or sometimes even in severe aortic stenosis, you might be seeing this pattern. And here, another pattern you need to be aware of is this like diminished diastolic flow. That happens when there is obstruction or stenosis or resistance to flow distal to the point you are measuring. So here you can see like pretty much there is no diastolic flow at all. And this can happen, actually it can happen even in severe venous congestion, or where there is severe renal vasoconstriction, such as in hepatorenal syndrome, or anything that diminishes the diastolic flow. Here is an example that I recently posted on Twitter that, I mean, this patient had retroperitoneal hematoma, and here is a normal waveform just for comparison, and here is that patient's arterial waveform. So you can see that the arterial flow is like pretty much diminished. Almost there is no diastolic flow. That's probably because of the pressure effect from the hematoma. Eventually, it would resolve. I mean, on the contralateral kidney, there was some diastolic flow. So we assume that it's most likely because of the pressure effect. So, I mean, when you do this Doppler, you can predict certain things. Okay. So what about the resistive index? So resistive index is also a popular topic, right? So it's renal arterial resistive index. So this also you would measure in the same vessels as you would measure, look for venous congestion. And in the arterial waveform, you take the highest point of this systolic peak, and that's a peak systolic velocity. And you take the end of the diastole point before the onset of the next peak, that's the end diastolic velocity. And resistive index is peak systolic minus end diastolic divided by peak systolic. It's like ejection fraction, like a big number minus small number divided by big number. And normal resistive index is less than 0.7, usually somewhere around like say 0.55 to 0.65 range. Resistive index is pretty non-specific marker. I mean, there is definitely evidence that it has prognostic significance, especially in ICU patients. More data is coming out. There was a recent study in cardiorenal syndrome patients that high resistive index confers poor renal outcomes, but still it's non-specific. So resistive index can increase in renal parenchymal disease, both acute tubular necrosis or chronic kidney disease. In obstructive uropathy, it can increase. In transplant rejection, it can increase. Just simply because you have bradycardia, it can increase, because in bradycardia, you have more time for you to diastole. So the diastolic flow is low, And in the formula, your end diastolic velocity becomes low and your resistive index goes high. And even in atherosclerosis and elderly patients, you can have increased resistive index. And you can have decreased resistive index when the patient has tachycardia for the opposite reason as bradycardia. You don't have much time for diastole, so your diastolic flow is higher and end diastolic velocity is higher. So when you put that in the formula, Ri goes lower. And in volume depletion, it can be low just because of reduced flow. And in glomerulonephritis, it is known, there was some old study that looked at like people with glomerulonephritis and tubular causes and compared the resistive index. It showed in glomerulonephritis, it's pretty much unchanged, assuming that glomerulonephritis is not associated with some kind of tubular inflammation. And yeah, it might have a role in distinguishing volume depletion from hepatorenal syndrome also, because hepatorenal syndrome, mainly it's because of renal vasoconstriction. That means it should lead to diminished diastolic flow. So that means the resistive index will increase. And why this is important is because, like, based on current definitions, we tend to volume expand these suspected hepatorenal syndrome patients for 48 hours to make sure there is no volume depletion, and then go to more definitive therapies. So if you are able to show that the resistive index is significantly high before you volume expand the patient, it's most likely related to hepatorenal syndrome itself and not really volume depletion. You might be able to avoid the load. You might be able to avoid additional volume that you give. That's one theoretical utility of RI in regular nephrology practice. But this is what I say. It's personal opinion that the practical utility of resistive index is low. I said resistive index increases in obstructive uropathy, right? So this is a recent patient I saw who had hydronephrosis. Measured the resistive index, see, like it's 0.57. It's much lower than 0.7. You can argue that you did not really measure it in interlobar vessel. You probably measured it in segmental vessel. I agree, but still, it's still intrarenal, and it's surrounding the hydronephrosis. So there must be some kind of pressure effect if you believe that pressure effect is leading to increased RI. So it's not always there. I've seen several cases, not just this one, but I've seen before that it's not always elevated in obstructive nephropathy. But anyways, like obstructive uropathy is least of our concerns when it comes to RI. So transplant rejection, like initially, like some people actually think like high RI is very specific for transplant rejection, but it's not really. And high RI or low RI is more useful in transplant kidney. One thing is you can easily do it because the kidney is superficial and you get better Doppler images, and the kidney doesn't move with respiration. So it's easy to put the Doppler gate on the vessel and it's not going anywhere. You get pretty pictures. Apart from that, in general, if you are able to rule out, like, if you're able to say that the resistive index has increased compared to before in a transplanted kidney, rejection is obviously the major concern you would have, and you can quickly biopsy this patient. So that's one of the reasons you would use RI frequently in transplant kidney, not because it is specific for rejection. Here is a patient who had transplant rejection, biopsy proven, but looking at renal resistive index at presentation, looked at like two different vessels. This is mid interlobar or pretty much arcuate vessel, was 0.69, and here is a lower portion of the kidney that's also 0.69. So it's not necessary that it's always elevated. So you can't just rely on that. And here is a normal kidney. I measured resistive index in the same vessel, same day, without changing anything, and there is like 10-point difference. So when studies show like a resistive index of 0.6 is associated with better outcomes compared to resistive index of like 0.75 or 0.7, it's very difficult. Like if you can have large, like this much discrepancy, and it can definitely vary from observer to observer, attending to resident, and like patient to patient, like your position to position. So it's very difficult to interpret in real life. And it's not everybody has good Doppler flows and you get good images, right? Here's one tracing obtained from a critically ill patient. It was very hard to even obtain like 2 full cardiac cycles, though we get some RI reading here. If you assume this is accurate and everything, we got some reading, but but unless you get like 2 to 3 cardiac cycles, you don't know how reliable that really is. Okay, so last part of the presentation, I guess we still have like 10 more minutes. And here is one case study just to like put everything together in terms of venous congestion and hemodynamics. So we have and just to show like how waveforms progress over time, because as nephrology consultants, we have the luxury of following the patients from like from the time of consult to the patient is discharged. So here is a middle-aged patient with known low ejection fraction. He was admitted for non-healing ulcer, possibly requiring amputation, some foot ulcer. And the baseline serum creatinine is 1.7 to 2. And at presentation, it was about 2.4. And the primary team resumed the home dose of Bumex. Interesting thing is, like 2 days later, the creatinine trended up 2.64 to 3.12 and 3.32. FE urea was 18. It's good. It's good that instead of FeNA, they used FE urea because the patient was on diuretic. That's a good thing. But still, the primary team has been writing it. It suggests pre-renal etiology. That's one thing. And pre-renal could mean anything. That's one thing. And you look at the physical examination, this is from the chart, and it looks like everything is fine. Regular rate and rhythm, CTAB is like, I don't even remember what that is. Like, anyways, like bilateral air entry is good, and no sounds were heard. And now looking at, this is the next thing we do, right? So you rely so much on weights and in intake and outputs in the hospital. So his output says like negative 860 cc, and the weight has dropped from 74 to 66.8 kg. And obviously you say, okay, so remeasure the weight. So the weight on remeasurement was pretty similar, like something like 67 or something like that. Still, it's a significant drop, 74 to something like that. What actually happened was like the patient was changed to another room from observation unit to floor or something like that happened. And this was not the same bed the patient was weighed the day before and now. But what can you do? I mean, you repeated it and it's pretty much the same. And with creatinine going up, FE urea 18%, physical examination being like super clear, and weight dropping, like what would you consider? I mean, most of the people would say it's over-diuresis, most likely, right? Because the patient was on some Bumex at home and they were giving just the same dose of Bumex, but in IV formulation. How much difference it makes in terms of bioavailability, we don't know. But assuming maybe IV Bumex has got achieved little more diuresis, people thought it's over-diuresis. But the nephrology team comes and performs a point-of-care ultrasound, which shows, obviously, we know that it's a low ejection fraction. LV is not beating well. There is biatrial enlargement, so chronically elevated filling pressures probably. And the IVC is plethoric and non-collapsing. Okay, this is suggestive of more congestion. So let's look at hepatic vein Doppler. Hepatic vein Doppler shows this up and down, up and down. I mean, one thing I can say is, I mean, is this possible? Like, is this could be A wave, S wave, V and D, and like this is pretty much normal hepatic vein waveform? We might, but it seems too symmetrical for, like, this seems to be S and D. That's one thing. And it could be this also, like where you have this S reversal and you have this only D wave below the baseline, which suggests severe congestion. Okay, the next question I mean, to know this for sure, you always want a EKG tracing. So with EKG tracing, you have this QRS complex here, and you can clearly see that whatever wave you are seeing below the baseline is only diastolic. So that is severe congestion. Now the proponent of over-diuresis comes and says, maybe this patient has like chronic severe pulmonary, tricuspid regurgitation. Maybe that's causing your wave reversals. I don't trust this. So you look for a tricuspid regurgitation. You look at the apical fourth chamber, you look at the, parasternal RV inflow, and it doesn't seem to be there is any like significant tricuspid regurgitation. So this is more likely related to volume overload. And look at the portal vein now. It's almost 100% pulsatile with significant systolic flow reversal. You have this QRS complex here, you have this flow reversal here. So that's also severe congestion. So by now you can say it's Vexus grade 3. And look at the renal vein, it's again D only pattern. Here you don't even need EKG. You have this arterial tracing here. So this is systolic, this is diastolic. You have flow only in diastole. That flow is also like a tiny bit of flow in diastole. That's severe congestion. So the patient was, we increased the diuretic dosing and everything. Now we follow. The follow-up serum creatinine was 2.47 from that 3 point something. It's a good thing. So it's definitely congestive kidney injury. And on follow-up, the IVC was still more than 2 centimeters with less than 50% collapse, though the collapsibility seemed to have improved. So this is again like subjectivity to IVC, right? Just depending on the IVC, it can, there are so many variables. Like you can always confuse IVC with aorta, you can confuse duodenum with IVC. You can confuse the caudate lobe of the liver with IVC. You can do many sorts of things, and the measurement might not be agreeable between your team members and stuff. But anyways, so the hepatic vein still shows similar pattern. And the portal vein, now you see that there is no systolic flow reversal. Now it's pulsatile, almost 100% pulsatile, say 80, 90%, but the whole waveform is above the baseline. So that's still good. And renal is still monophasic or D-only pattern, but the flow seems to have a little bit increased. You can say it might be subjective, but still it's occupying more part of the cardiac cycle. And another follow-up, creatinine is even better, 2.1. IVC is still more than 2 centimeters, but hepatic vein looks similar. And the portal vein, the pulsatility has significantly improved again. And the renal vein looks like the systolic component was starting to appear. And also the diastolic flow has improved in terms of duration during the cardiac cycle. So what I'm trying to say is like portal vein is probably the first one to improve during the decongestive process. Even if the IVC is more like big, continues to be big, you know that whatever you're doing is right because your portal vein is improving. And further follow-up. On further follow-up, interesting thing was, the hepatic vein seems to be improving. So the above the baseline component has pretty much diminished, and there is more flow below the baseline. And portal vein has almost normalized. And the renal flow is also, it's pulsatile, but still good. But the creatinine went up to 3.1. What could be the cause? Maybe the forward flow is the problem, right? That's what we would think about. Looked at the LVOT VTI, it was about 11. I did not measure it before, so I don't know how much it is. But anyways, before we even could do anything, the patient was taken to the OR for amputation, and the patient went to ICU and had some hypotension during the surgery and required CRRT, as usual. For any major surgery, CRRT is a norm these days. So he even got dobutamine for a brief period in the ICU and started on CVH. After that, followed up on the waveforms. Again, hepatic seems to be nicely improved now, and portal is normal, and renal spectacularly normal. So it's perfect decongestion. And looking at the IVC here, so here is the IVC. It's pretty small. It's initially, remember, it was so big. I'll show you the comparison. So initially it was like this. It's so big. It was actually on the first follow-up. And here is the final IVC prior to discharge to rehab. So you can follow the decongestion pattern over a period of time. And it gives, it's an additional add-on point to your IVC or whatever you use. I'm not saying this has to be used. This is the primary thing that you have to use, but it definitely guides your therapy. Another simple, quick study. Here is one patient who had relatively prolonged hospitalization for some heart surgery, and she had some heart failure. And patient, this is the day of discharge, and the patient was feeling fine, wants to go home. And the primary team, which was I think cardiology, whatever, they also felt that she should be discharged home. It's just that the creatinine went slightly up from 1.35 to 1.46, but everybody thought it's fine, right? It's fine because we generally say the rise in creatinine during the adequate decongestion process is probably benign. That's fine. And they say follow up with renal in 1 month. She's net -7 liters. Everybody puts that in the note and says very happy about it. And discharge, on the day of discharge, I did this ultrasound. It shows IVC, big IVC. It's not clipped, but it was relatively plethoric. And hepatic vein, I did not have EKG that day, but still, you can see that is most likely it's D only pattern. And portal vein, you see this 100% pulsatility with systolic flow reversal, like exactly you saw in the previous patient. And renal, it was monophasic D only or diastolic only flow. That is severe congestion. I scanned her like 2 days ago, and the IVC was similar, big, but anyways, the portal vein was like this. So there was no significant systolic reversal, and it seems to be less pulsatile compared to this one. So definitely the congestion has worsened despite patient feeling fine and everything. But unfortunately, the patient was discharged because she was feeling fine and wants to go home, and gave follow-up appointment in 1 month. But I spoke to nephrologist and they arranged a follow-up in 1 week, but I did not think it was really enough. Anyways, like looking at subspecialty notes, like one is cardiology note, one is primary nephrology team taking care note. And they say like pulmonary, it was clear. Actually, I saw B lines in all the sono-auscultated zones. And both notes say pulmonary clear to auscultation, then there was no mention of JVD. And the patient came back in 3 days and was admitted to ICU and had a prolonged course again. I mean, I don't know whether that admission could have been avoided or not, but definitely that the pain of going home and like having this quality of life issue would have definitely avoided. An elderly patient with CHF was consulted for worsening renal function. This is another latest case. So I was like, here is the big plethoric IVC. And interestingly, you can see the D-shaped septum here. So that's one thing to remember. It's probably both in systole and diastole. It's probably both. He has some pulmonary hypertension, also probably both volume and pressure overload. And looking at the vexus, here I have the EKG. And this can be confusing without EKG because this patient had arrhythmia. But here I can clearly tell based on the EKG that it's only like D wave that you're seeing below the baseline. And the portal vein is almost 100% pulsatile. So we started him on ultrafiltration. And after 2 days of ultrafiltration, IVC was still big, but you can see that the hepatic vein nicely, both systolic and diastolic waves appeared below the baseline. And the portal vein slightly increased pulsatility probably, but almost pretty close to normal. So this is how we monitor the efficacy of decongestive therapy, despite IVC being on the higher side, like bigger side. And very interestingly, the D-shaped septum disappeared and LV became round. This is one of the interesting scenarios where if you ultrafiltrate the hypotensive patient, actually that hypotension might improve because you're removing the volume and that RV is no longer pushing on the LV and compromising the output. Here is last example just to show. I mean, there are nephrologists also here. You might ask like if you would do this in ESRD patients. Yes. I mean, we don't do like, I never did kidney Doppler in ESRD patients. It's hard. The Doppler doesn't pick up that well, but look at the portal vein and hepatic vein. That's a good way of measuring. And here is a ESRD patient volume overloaded. At presentation, you can still see like 100% pulsatile portal vein with flow reversal. After 6 liters of ultrafiltration, all the portal vein tracing is above the baseline with decreased pulsatility, and it normalized after 13 liters ultrafiltration. Same is the case with hepatic vein. So initially D only pattern, and both S and D waves appeared below the baseline after 13 liters of ultrafiltration. In this image, you can still see some pleural effusion, and all. The patient had some hypervolemic issues, but you can, yes, still use it in ESRD patients. So regardless, whatever you do, I mean, no sonographic parameter should be used in isolation, and a fool with a tool is still a fool unless you properly clinical integrate. Thank you so much, and hope it was useful. And that's it. I mean, there are not many Vexus scenarios on nephropocus.com yet, but I'll start doing it from next month. Thank you.
I think there was a question earlier. If you look, there was one posted about 138 about how hard do you try to align the direction of blood flow with your angle of insonation when you're doing your Doppler measurements in the liver and kidney?
So, yeah, that's a very good question. So, should we correct the angle? So one thing is obviously you get good Doppler flows when you're aligned more parallel to the vessel. So we anatomically try to be as parallel as we can. If you're enthusiastic, you can definitely correct for the angle. So the thing is, you're just analyzing the pattern, right? So the pattern of the blood flow is less dependent on the angle compared to the absolute velocities. So if you are dealing with absolute velocities, you're doing a renal artery stenosis study, you would want to definitely correct the angle, otherwise you would get wrong values. But if you're looking for a pattern, it's not always possible to correct the angle. You just try to align the vessel as parallel as possible and get your tracing. That's good enough for most practical scenarios.
When you get these heart failure patients, what is the buy-in or lack thereof from your cardiologist on this? When you present them, when they consult you on worsening, kidney function, and you show them, here is what I found on Vexus. Are they buying this or not?
I don't think they're buying it yet. I mean, I'm trying to force it on them by, like our images are available in Epic in a separate place, like you get the radiology image. But I also try and take time and put my images in the note so that like it's on their face when they open it. But I don't think like most of them buy. But I'm doing the cardiorenal clinic also now, like following this pattern, patients longitudinally in the clinic and seeing how this would change. And I think that's going to have a better effect. I mean, most of the time I'm not the primary nephrologist. Like I do like POCUS consults a lot. So nephrology team will be seeing the patient and they call me to do POCUS. So I don't really interact directly with most teams.
Just out of curiosity too, I know we have some nephrologists that are still on here. I don't know if they have any input or feedback on their own experiences with this or plan to integrate this.
Looks like no nephrologists.
I think there's a couple. I think they're just staying quiet.
Yeah. I can try to answer that question. I've been trying to talk with a lot of our nephrologist colleagues here, especially Ali and Dr. Tallaricio, and we have been discussing about trying to do it more and more, especially in our ICU patients. One of the, I work a lot in the liver ICU, and that we see a lot of hepatorenal syndrome, and that is one group I'm really interested in looking at the Vexus score and the renal resistive index pre and post. Providing them with fluids or like norepinephrine or whatever therapy. So we have been trying to talk about it, but COVID has put brakes on everything that we are doing right now. But I'm very hopeful that, maybe next year we'll have much more information about how we will be proceeding with that, especially in our liver patients with AKI.
That's a very interesting thing. Yeah, I mean, like, this patient group is like very tricky group, right? With you don't know how much to trust the portal vein, and the hepatic vein waveforms can be fused and stuff. So we need to take multi-parametric approach. And actually, we also have like very big liver ICU, and our nephrology chief is so much into hepatorenal, and we are planning a study as well. Hopefully early next year. That protocol is in progress.
That's great. I had a question about the Vexus score. Bob, is it okay?
Yeah, sure, go ahead.
Yeah, so one of the things that since we have been seeing all COVID patients and all of them are on very high ventilator support, especially with the PEEP and everything, and a lot of those patients, when we have been doing Vexus, we have been finding they have a lot of pulsatility. And before that, I haven't gone through the literature in depth, but like how much does the pressure and how much of it is volume that affects the pulsatility of both the portal vein or intra-renal vascular Doppler? Like if the patient may have okay volume, but if the pressure on the right side afterload is pretty high, will you see the similar pattern, or there will be a difference between them?
So I think Eduardo will be able to answer that, but I would say one thing I would say is like we see the similar pattern. Like obviously, like if you have like severe pulmonary hypertension, we see similar pattern. And there was a recent big study which showed the prognostic value of renal congestion, showing that the monophasic is bad. But based on what I saw in these patients, like these patients can also get volume overloaded, right? So like portal vein tends to get better with treatment of volume overload, while hepatic and intrarenal might still stay the same. That's what I've been seeing in like outpatients with known significant pulmonary hypertension on these vasodilator therapies and stuff. The portal vein is not always necessarily this bad with systolic reversal. But when that happens and when clinical history correlates with more of a volume issue, we use portal vein as a guide. But Eduardo might have more insights.
Yeah, no, I agree. I think it's impossible to differentiate pressure overload from volume overload causing secondary pressure overload, or venous congestion can arise from both conditions. At least we can say that if you were actually considering giving fluids to these patients, the fact that they're severely congested can definitely tell you they're probably going to get worse with volume loading. Now, whether is it useful to start diuretics? I think that's a different question. Many times I do, especially if you have congestive organ injury. So if you start seeing, increasing bilirubin or delirium, for example, congestive encephalopathy, congestive kidney injury, and you have a Vexus 3, a very pulsatile portal vein, flow reversal on the portal vein, like Abhi said, then it's a good bet. You can either fix the heart if you can do that, but if this is a chronic cardiac condition, or this is a mechanically ventilated patient with high pulmonary vascular resistance, probably from a severe respiratory distress syndrome, I think it's a good bet that diuresing this patient to a less congestive state, to a less pulsatile portal vein, could actually result in improvement in organ function, maybe improving delirium, improve hepatic function, and in lower serum creatinine. So I think that's how you can think about it.
That's great. Yeah. And also, I would say, if the renal function is stable, I'm talking more from outpatient perspective. If the renal function is stable, but still the renal vein shows monophasic pattern, I tried to diurese a couple of patients, but they didn't respond well. So I think it's probably unnecessarily reduce the afterload, right ventricular afterload that the patients are accustomed to. So that's one thing I would advise caution.
Yeah, that's one of the thought process I'm having is just how patients who have echo or a drive it. The perfect example for me is drive it. How any end-stage renal disease patient has a drive it, they should also have a baseline Vexus score in their chart. So at least we can, when they come into the hospital, we can at least know where do we want to get them, rather than trying to guess it out and maybe cause undue harm to the patient.
Hopefully by the time you retire.
There was another question about, do you peak at relative LV filling in your plethoric IVC patients?
I don't necessarily always do, EE prime or anything like that. In some outpatients, I just look at the E wave deceleration time. But apart from that, I think lung ultrasound gives a good idea of LV filling. That's what I stop at. Usually IVC, Vexus, lung ultrasound, and in heart would be more in the outpatient setting.
Yep.
In cases where you're having a difficult time due to respiratory translation, getting the Vexus parameters, do you ever go to the femoral vein to try and seek answers?
I don't do femoral vein, but obviously there are new studies that's pointing towards doing that, and it might be actually worthwhile for physicians who put femoral lines. You can do the Vexus assessment at the same time, but I really have no experience. I never used it. I didn't have the need to use it.
I've used it a couple of times, the femoral vein. I remember a case where the patient had severe subcutaneous emphysema because of spontaneous, she was mechanically ventilated, spontaneous subcutaneous emphysema. It was impossible to use ultrasound in all the upper body. So the only way to monitor this patient had right ventricular dysfunction. And the way that I used to monitor was actually femoral vein Doppler. Femoral vein Doppler gives you very similar information as the hepatic vein Doppler. This is just a very continuous venous system. So, I mean, important flow reversals can definitely point towards, this patient has severe tricuspid regurgitation and probably still volume overloaded. So it can definitely help. Haven't find it quite useful except for these extreme situations.
Can I just ask, I think
Sure.
I don't know what the time is, but one of the topic that I'm very interested in, I wanted to hear Eduardo and Abhi comment on that, is have you tracked patients, I'm a big believer of intervention pre and post, so more dynamic measurement than static. So in renal resistive index, have you looked at response to therapies in hepatorenal syndrome? Have you assessed that?
I mean, not so. My practice in hepatorenal syndrome is, the problem is by the time nephrology is consulted, the transplant ICU will want CVVH. So they call saying I put the catheter, come and put CVVH orders. That's how it is, unfortunately. But I did notice elevated resistive index in people and to help diagnose HRS. And also I noticed some patients have elevated cardiac output. That way you can avoid the fluids and recommend early vasoconstriction. And pre and post, I did not do, but there are data suggesting that pre and post paracentesis resistive index decreases, but we have to do it on a large scale. Yeah.
Yeah, I could comment a little bit more. I mean, we see a lot of patients with chronic liver disease, and I've done this in many patients with acute kidney injury, but usually I see them when they are relatively sicker. They may have a sepsis, and they go to the intermediate care or maybe ICU. And yes, I've seen a very high renal resistive index associated with oliguria improve fairly quickly when you start the patient on vasopressors. So this is either norepinephrine or vasopressin. And usually when you see this elevation in RRI is reversible, whatever that means. It usually means that that the alteration is not permanent. So probably the renal dysfunction is going to get better. Whether this is actually showing the pathophysiology or the physiological way in which vasopressors improve urine output, I'm not entirely sure. Because most of the time the renal resistive index it's actually not a resistive index, it's a pulsatility index, right? And so if the patient has a high pulse pressure, like in distributed shock, low diastolic and maybe higher systolic pressure, so the RRI is going to be large, the large pulsatility index. And when you start vasopressor, you actually lower pulse pressure because you're raising diastolic blood pressure. And so maybe this is why you're seeing a decrease in the RRI. But the fact that it was reversible, you can kind of use that to know that renal function is probably going to improve. And I've seen this time again. If the RRI gets better with vasopressors, the patient will start producing urine. So you can know this beforehand.
That's a great point. So yeah, usually RRI improves if it is a temporary thing and the ATN has not completely set in. So that's why the data is really conflicting with these studies, that some studies showed improvement with norepinephrine resistive index, and as the patient's hemodynamics improved, and some studies did not show. And the studies which did not show the difference, we believe it's probably because they are more sicker and probably they already have ATN.
Anyone else have any other questions? I think maybe one other thing, Abhi, what's your take? I know you posted yesterday and Eduardo had responded. What's your thoughts now about atrial fibrillation and how you're interpreting those fused S&D waves?
So, I mean, first thing is we need to have EKG. That's one thing, because especially it depends on specialty. I mean, some specialties you would see EKG first. I mean, I might not actually see. I mean, as a nephrologist, I might just look at the chest X-ray and go see the patient. So I might not even look at the EKG. So yeah, first of all, we need to have a simultaneous EKG, and because the S wave partly depends upon how the atrium is relaxing, because during ventricular systole, the atrium has to relax, and that is impaired in atrial fibrillation. The S wave, the amplitude of the S wave seems to be smaller. So even without any congestion, you can have smaller S wave than D wave, that is S lesser than D pattern at baseline. That's one thing. And depending on the heart rate, you might have fused waves. And in the case I posted, actually the patient did not really have like super high heart rate, because we normally assume that you don't have time for diastole, so S and D waves fuse when you are hyperdynamic. But that patient actually had fused S and D, like with a heart rate of 80s or something like that. And that fusion is also not the same cycle. So the D wave of the previous cycle and S wave of the next cycle. So it happened before also, like I posted some other case on Twitter. Initially, I didn't believe, but it appears that does happen. And I don't know the exact logic. I mean, it's probably because of atrial fibrillation also, but I saw that even in patients who do not have atrial fibrillation, that like the previous cycle and current cycle fusing. That's probably just that commonly happens. I just don't know.
Yeah, so I don't have the necessary cables to get the EKG simultaneous with my Doppler tracing, so I don't even bother. I mean, in patients with atrial fibrillation, I see a bunch of waves. If I see a lot of flow below the baseline, then I know who's probably has some normal venous return. But I look at the portal vein. So the portal vein, even with atrial fibrillation, if the patient, I mean, Abby showed some pretty nice cases of a patient with arrhythmia. And even if the patient's arrhythmic, you can still see, with each beat of the cardiac cycle, you see pulsatility. It's usually not very variable from one cycle to another. It can be. So if it's really variable, I would, take like maybe 10, 15 cardiac cycles and average the pulsatility. But I mean, if you see very increased pulsatility, then I don't really care about the name of the waves on the hepatic vein Doppler. I know the patient's congested, and then I try to do something about it.
Yeah, I guess it's mainly important, like if you're doing a study and documenting it, probably that becomes more important than day-to-day clinically. Like as you exactly pointed out, like if the more flow is towards the heart, that's what you care about.
Would you guys maybe be willing to share on Twitter some examples of like your reporting, or if you have templates that you use in Epic, how you do your reporting of some of these studies?
So I just normally put it. So first, I mean, you probably, I don't know like what we use, but anyways, like we use Epic and we place the order for the Doppler scan, and the images are available in the packs, and that's connected to the patient's chart. And in the note, I just put a consult note and put the same necessary stuff, like what is the indication for the study, and what are the findings, and what is the impression, like you do any other study. I did not really put any specific template. I mean, I just put like IVC, hepatic vein, portal vein, renal vein, performed or not performed, and if performed, what findings. So that's my template. That's it. As simple as that.
Yeah, that's exactly what I'm doing.
Okay, that's helpful. All right. Let's see if does anyone else have any other questions? I know we've gone over, but I think there was great interest in this. And again, we really appreciate the two of you coming and being willing to do this.
Thank you.
Thanks, Dr. Jones.